Before any clinical examination, wash your hands. Observe the patient from the end of the bed, checking if there's any respiratory distress, change in colour. If there's any SUS charts or vital signs charts at the end of the bed, take notice of the results. Introduce yourself to the patient, check their ID, explain to them what you're going to do, and gain their consent before proceeding on to the examination. Start off with a general examination, looking at the hands for any sign of clubbing, Dupuytren's contracture, any nail changes, any palmar erythema. Check the pulse for rate, rhythm, volume, character. Check if there's any collapsing pulse by elevating the arm, ensuring that you ask the patient if they've got any shoulder pain. Move on to the face, checking for any anaemia or jaundice. Look in the mouth for any signs of glossitis or ulcers. Check that the trachea is central. Move the head to the side and check if the JVP is elevated. Feel for the carotid pulse, again feeling for rate, rhythm, volume, character, remembering to examine one pulse at a time. Auscultate the carotid artery for any evidence of carotid bruit, again auscultating one side at a time. Inspect the chest, looking for any deformities, spider nevi, any respiratory distress. Feel for the apex beat, any heaves or thrills. And then listen to the four heart areas. Listen for the mitral valve, the tricuspid, the aortic, and pulmonary. You can time a murmur by feeling the carotid. If you feel the pulse and you hear the murmur, then it possibly is a systolic murmur. If you think the patient has the murmur of mitral stenosis, turn the patient onto the left side, best heard with the bell of the stethoscope, and the murmur of aortic regurgitation is best heard with the patient sitting forward at the lower left sternal edge with the patient in full expiration. Check for chest expansion, and since this patient has complained of generalised pain in the chest wall, checking for tenderness. Percussion, checking that both sides are resonant, remembering to compare like with like. Auscultation for breath sounds to check if these are vesicular or if there are any added sounds of rhonchi or crepitations, and also vocal resonance. With the patient sitting forward to examine the posterior aspect of the chest, you can palpate for cervical lymphadenopathy. Again, on posterior chest examination, check for inspection, symmetrical expansion of the chest, percussion, and auscultation. Again, auscultate for breath sounds and vocal resonance. Again, when percussing and auscultating the posterior aspect and lateral aspects of the chest, remember to compare like with like. With the patient sitting forward, remember to check for any signs of sacral edema. Check that the patient can lie flat without becoming breathless, so that abdominal examination can be performed. This must be performed with the patient horizontal and a pillow beneath the head. Abdominal examination exposure must be from nipple line to pubic symphysis. Check for any scarring, any deformity, any evidence of pulsation, or any evidence of masses. Check that there's no tenderness and your hands are warm. Initially, palpation is superficial to check for tenderness, watching the patient to make sure they don't grimace and getting them to tell you if it is sore. Follow this by deep palpation, again for any tenderness or guarding, and checking for any evidence of organomegaly. Palpation should then be performed for any evidence of organomegaly, liver, spleen, and if clinically indicated, ballottement for the kidneys. Percuss for organomegaly for the liver and spleen, remembering to percuss from resonant to dull, and if any evidence of ascitic fluid, percuss for shifting dullness. Finish abdominal examination by auscultating for bowel sounds, checking the hernial orifices for any hernia, groin area for any lymphadenopathy, and in men any evidence of scrotal or testicular pathology. You can then perform a screening neurological examination, starting with cranial nerves. Check that the patient has had no difficulty with smell before moving on to the other cranial nerves. Eye movements, which checks 3, 4 and 6 cranial nerves. Checking the ophthalmic, maxillary and mandibular division of the 5th cranial nerve for any sensory deficit. The motor component of the 5th cranial nerve, which is the muscles of mastication, asking the patient to clench their teeth. The 7th cranial nerve, the muscles of facial expression. The auditory component of the 8th cranial nerve can be checked by checking if the patient has had any hearing deficit. 9th and 10th cranial nerves can be checked together. 11th cranial nerve or the accessory nerve can be checked by checking power in trapezius and sternomastoid muscles. The hypoglossal muscle, checking the power and tongue and looking for any fasciculation or wasting of the tongue on protrusion. We then move on to neurological examination of the upper limb. Start by inspecting for any muscle wasting or fasciculation or deformity of the limb. Check the tone. Power. Again, checking like with like. Checking for sensation. Sensory modalities that can be checked are light touch, pinprick, vibration and proprioception. Ensure that the patient is aware of the stimulus being tested. Check like with like, ensuring that the patient can feel and it is the same on both sides. Sensory testing will be dependent on the presentation and clinical examination findings. Thus, testing for peripheral neuropathies or reticulopathies will vary slightly when undertaking the examination. Checking for reflexes. Again, ensure the patient is relaxed, checking like with like. We then move on to look at the legs, checking for any evidence of rashes, edema, ulceration, not forgetting to look between the toes and under the shins and heels of the foot. Check for temperature. If you find any discrepancy in temperature and there is a suggestion of peripheral vascular disease, ensure that peripheral pulses are checked. For neurological examination, again, check tone, comparing like with like, power, checking like with like. Again, sensory testing. Ensure that the patient is aware of the stimulus being tested and get them to close their eyes, telling you when you're touching them, and if it is the same bilaterally. They must close their eyes so that there is no visual stimulus to sensory sensation. In a patient who is diabetic, who has peripheral neuropathy, remember to check peripheral pulses and also monofilaments for peripheral neuropathy. Reflexes of the lower limb. If there is problems eliciting these reflexes and you feel the patient is not fully relaxed, then you can use reinforcement by getting the patient to try and pull their hands away from each other while striking the tendon. If you have not observed the patient's gait prior to commencement of examination, ensure that you ask the patient to take several steps, watching the gait for any truncal ataxia, ataxic gait, paraplegic gait, etc. On completion of the examination, explain to the patient any findings you have elicited, thank the patient, and wash your hands. If the patient's vital signs have not been monitored, please ensure you check blood pressure before completing examination.